As always, refraction is slightly neglected in most of the teaching institutions. And recently we had virtual examinations for DNB. There were quite a few questions on refraction and retinoscopy, even on the practical side. So it is important for every PG to know every aspect of vision testing, retinoscopy, and allied testings. One more important thing is this is the foundation for any hospital. If the initial refraction is not done properly and your assessment is not good, your overall prediction of what is going to be the case and assessment of the case and workup will not be good. So this is very simple. You all know it is like a camera, especially the new PGs. The image is inverted and it is taken back to the back of the brain, the occipital cortex. So we are not going into all that. We are more bothered about what is the refractive apparatus in this particular talk. So there is the corneal system and the refractive system, the lenticular system. So there are different constants like refractive index, curvature, refractive status, and the various power and cardinal points. Corneal system, again, starting from the lacrimal fluid to the posterior surface, can be around 43 diopters in power. The lenticular system can contribute about 18 diopters in power. And you have the refractive indices, which vary from the front to the back. They are not the same. That is what we must remember. So there are many ways of finding out what is the refractive status of the eye. Now, routinely, everybody goes for an automated refractometer, assume and do a subjective and give glasses. But this art of retinoscopy, age-old art, is still good to find out some of the rare powers, difficult situations. So basically what happens, the refractionist plays a major part in finding out what is the refractive problem and also talk to the patient. It is most important that this is followed by talking to find out. They may have a 6/6 N6, but there may be a distortion of vision. There may be difficulty in near. There may be one eye that is. So this history taken by them will also make them know. They may have to go and do Amsler grid. They may have to do certain tests. So this is the basis on which we are going to do retinoscopy, which is also called as skioscopy. Basically, we are going to put a light into the eye of the patient and the observer is going to observe. So depending on the distance between them and depending on what is going to be the reflex, you are going to assume what is kind of the power. So there are three basic stages of retinoscopy: the illumination stage, the reflex stage, and the projection stage. Illumination, it illuminates the subject's retina. The reflex imaging of this illuminated area formed by the subjects is by the dioptric apparatus, and projection of the image by the observer. Depending on where it falls, the various types of retinoscopy reflexes will occur. So basically, retinoscopes are plenty. You have reflecting retinoscopes, the manual ones, and now we have the automated ones, the electrical ones, which are self-illuminated retinoscopes. So this is the one which is going to decide. Basically, all of us use only the self-illuminating retinoscopes. There are two models. One is a Copeland model and the other one is a Welschalen model. So basically, there are two parts: observation system and the illumination system. What we need to know is the Copeland and the Welschalen are opposite. For example, in a Welschalen model, the sleeve should be down for you to get a plane mirror. That is what we mostly do retinoscopy, 99.9%. If the sleeve goes up, then it becomes a concave mirror. So all the reflexes will change. Always there is one question: is there a role for a concave mirror? Not really. Not many people use it, but in extreme powers like high myopes, it may be of help. So there are two types of retinoscopy. One is the dry and the other one is wet. When we mean wet, it is after a cycloplegia, either atropine, homatropine, tropicamide or something like that, not the phenylephrine. Dry is without putting a medication. It can be static or dynamic. By static, we say your patient is going to look at a far object and the pupil remains static. But if the patient is going to look into the light, it will become a dynamic retinoscopy. The working distance, ideally 2/3 of a meter is ideal because it's an arm's length. Why? So it is easy for you to pick up the lens and put it in the trial frame. But I tell the PGs to do 1 meter for an exam so that you do not have any confusion regarding working out the problem. Shorter distances will be half a meter. So based on this, you'll get a distance correction. 1 by 1 straight away will be 1. For 2/3 of a meter, it will be 3 by 2. it will become 1 point. The correction of distance will be 1 point. If you do it half a meter, the correction for distance will be 2. That's all. Just reverse it and put it. So this is how you work out the distance correction. So this is something what you're going to see, the reflex in the pupil. It can be in an undilated pupil like static or dynamic, or it can be in a where it is wet retinoscopy. So this is important. And what you're going to observe is like this. When you see through the retinoscope, if you put off the light, maintain the distance. This is the reflex we will be seeing when you throw the light into the patient's pupil. Ideally, you start off with dilated pupils only so that you get a feel of the reflexes. Now, this is the model eye which is available. You can change the power of the eye, you can change the cylinder of the eye, and you can set it up, put a trial frame on top, and you can do your trial retinoscopy instead of sitting for half an hour, 1 hour on a patient and taxing him. This is the first feel you must get, and then you can go and start doing on a patient. There are different characteristics. The speed, the faster you are, you're nearer the neutralization point. Slower, you're very far away. I mean, if it is -3 or still at -2, it will be fast, slow. If you're going to be -0.5 for 0, it will be faster. So the reflex is slower and faster. Speed is also there, and the brightness. It will be dim as you are far away from the focal point. It will be brighter as you come closer to the focal point. Here you can see there is a width movement in the first image, and the second movement, nothing is there. It is just filling up the pupil. And the last one is you're seeing against movement. So these are the 3 things that can happen. So depending on your working distance, this 1 meter or 2 meter will occur. This is for a 1 meter retinoscopy. So what happens if you do at 1 meter? This is what will happen, that you're sitting at 1 meter. For an emmetrope, it will come as +1. So if you -1, it will become 0. So if you're getting a neutralization without any glasses, that means plus or minus, then the power would be -1. That is what I'm trying to mean. So retinoscopy reflexes will be for an emmetrope or a myope less than 1 diopter and hypermetropia. It will be with movement. Myopia of more than 1 diopter will be against movement. Myopia of 1 diopter will be no movement. Okay. So it means -1. Plus or minus will become -1. This is the basis. So with this understanding, you must know how to go and find out the point of neutralization. When the pupil is completely illuminated, there is no movement at all, then it is filled. It is a neutralization point. You want to verify, supposing at -1 becomes at neutralized, you put a +0.25. So with movement will become opposite movement. Opposite movement will become same side. So it will become same side. That is it. The movement will reverse. So far, +2, you have been having a with movement. At 0, no movement. If you put a -0.25, it will become against movement. So this is the ideal way to find out a neutralization point. So this is one thing which will really show how to do it. It is a simulator available in the net. So you can see what is the movement there. You see it is becoming narrower and faster. So you go on putting the plus lenses, and then at the point it will become full. Very shortly, as you see it becomes full, then that will become the neutralization point. This is something for you to get a feel. See, now it is almost filling. No, it is a neutralization point. You can find out at that point. So this is something which can also occur. Supposing you play the reflex, normally what you do it at 90-degree and 180-degree axis. Sometimes you can see your beam moving in one side, but the reflex is not parallel to the beam. Then you get some kind of abnormality in the reflex. This is called regular astigmatism. That means they cut at 90 degrees, but they are not at 90, 180. So there are 4 characteristics of a streak reflex when you have an astigmatism: the break, the width, and so on. So the break is when you put the beam, the reflexes in the pupil and the beam inside the pupil do not match. So there is a break. It is as simple. So this is called as the break. And when you have the width, again, they don't match in the same axis. There is not neutralization. Only if it all becomes together in that particular power, it will be neutralized, and it will be same as on the iris as well as on the pupillary area. So the intensity, as you come to the neutralization point, it will become brighter. skewing. So skewing is nothing but one goes in one way, one direction. The other also may go in the same direction or opposite, but it will not be parallel to that. So what you want to see here is this is the skewing. You can see that there is skewing. Can you see that? 1 minute. Okay. You can see how it is skewed. That is why it is called skewing. So with two spheres, you can neutralize separately, or you can put a sphere and a cylinder in the opposite axis. But ideally, we teach you neutralize separately each of the axes so that then later on it will be easier for you to calculate. So that is information. That is the most important aspect to neutralize. What is straddling? So there is something called Jackson's cylinder where you want to fine tune the cylinder. Here in retinoscopy, it is similar. Supposing you have a neutralization at one particular axis, then you have to do 45 degrees turn on both the sides. You understand? So you can go 35 on one side and from 35 to 45 other side and the 45 other side. So when you do that, the narrowing should be the same and the speed should be the same. That means you are in between. Supposing on one side it is better, one side it is much worse. That means your actual point of neutralization axis is wrong. So you test on both sides 45 degrees on each side, then you will get the correct axis. So that is the basis of retinoscopy. You can get abnormalities when there are opacities, when there is abnormality in the shadow, when there is corneal scarring, or if there is a tilt in the lens or keratoconus. Most important is this one. Previously, we cannot do any kind of dilatation if you get scissors of the shadow because it is likely to be a case of keratoconus. And then what we need to do is we need to take up for topography. But now we have modern pentacams where you can even do topography with dilated pupil. So what do we mean by a scissoring? Upper part will move in one direction and the lower part of the beam will another direction. That's all, like a scissor. It will move on opposite directions. That is called a scissoring. So if this is found, you always think of a curvature abnormality and proceed to find out curvature anomalies. So the irregular astigmatism, optical opacities can be there, high powers can cause difficulties. This is how you calculate. So I've already told you working distances for 1 meter, 1 for 0.5 at for 2 meters and so on. If you're doing at 1/3 of a meter, you'll get minus 1.5. Now, what are the drugs we use? We can use atropine for very young children, homatropine, cyclopentolate, and tropicamide. For atropine, you give a drug correction of -1. For homatropine, you will give a correction of minus 0.5. So there is always 0.75 or 0.5 for cyclopentolate. Some people say there is no need for drug correction for tropicamide, but we do say there will be some amount of, because it is not a total non-cycloplegic. It is got about 0.5 to 0.75. So you need to understand that when you do a tropicamide refraction. Now, when do we give drug corrections? Remember, the first and most important rule is only for plus sphericals you will give a drug correction. Never give a drug correction for minus spheres or cylinders. So that is number one. Number two, even plus spheres, you do not give drug correction in conditions like mixed astigmatism. I will tell you why you don't give. Because there the plus sphere will become a minus sphere. So then it becomes difficult. Pseudophakia and aphakia, there is not going to be accommodation. Presbyopia case, there is not going to be accommodation. So except in mixed astigmatism, pseudophakia, aphakia, and presbyopia case, you will give drug correction for plus spheres and no drug correction for minus spheres and cylinders. So this is the basis. There is another thing you must remember, when you have this protractor on the eye, you can see the horizontal axis and minus come together. Vertical axis and plus come together, just like you draw a line. If this is occurring, we call it with the rule astigmatism. You invert it. That is, horizontal will have a 90 and you will have a 90 plus minus and you have a plus at 180. This is the opposite. Okay. At horizontal, you will get minus and vertically you will get plus. That will be with the rule axis and the protractor is wrong. And if you get a plus at 180 and minus at 90, it will be against rule. I'm sorry about the figure. So the steps of retinoscopy is something which I should cover in the next 10 to 15 minutes. Always remember in the exam, refraction steps of retinoscopy are very important. You don't go do retinoscopy plus 1.5 to 180, give a prescription and write. That is all. 2 steps. You will not be correct most of the times. So if you go properly, the patient, you have to know so many things. One, age of the patient. What is the drug that has been used? Number one. Number two, what is the reflex you get and what is the neutralization in each axis? This you call the retinoscopy power, or you can call it the power cross. So if I say plus 2.5 180 and plus 3.5 at 90, second thing you must do is you must do a distance correction. So I said 1 meter, you minus 1 straight away, whatever may be the problem. So you make it plus 2.5 and plus 1.5. Is that clear? 3.5 minus 1 plus 2.5 plus 2.5 minus 1 will become plus 1.5. So that is correct. Okay. So once you get the distance correction, remember there are two things we have. One is the plus 1.5, the other one is a plus 2.5. Amongst both the powers, take the smaller power. Always remember, take the smaller power and use it as the spherical power. So plus 1.5 will be given as a spherical power. When we say sphere, it acts at all the 360 degrees. That means everywhere you have a 1.5 spherical. Now what do you want at 90 degrees? You want 2.5. So already 1.5 is there. So you have to give additionally how much? 2.5 minus 1.5 will be 1. So you have to give another plus ones. Remember, when both the signs are same, you subtract. When both the signs are opposite, you have to add. Supposing it's minus 1.5, you have to neutralize that. Then you will say plus 4. But here it is plus 1.5. So plus 1.5 plus 1 would make it plus 2.5. So you give plus 1.1 at 180 degree. You know why? Because if you give at 180 degree, it will act at 90 degree. Opposite to the axis where you give, it will act. So you give a 1.5 spherical, it is there all around. You give a 1 diopter at 180, it will act at 90 degree and give plus 2.5 at 90. Is that clear? This is the most important point. Then you get plus 1.5, 1 at 180. Now, can we leave it like this or just give it like that? No. Because when you give to a patient, there are two aspects. There are equivalent powers to this. A minus cylinder is better accepted than a plus sphere. Though the powers are same, for the patient to accept a minus cylinder will be a lot easier. So you have to transpose. What do? You calculate both. Plus 1.5 plus 1 is how much? You just add. It is plus 2.5. Just plus 2.5 in a spherical. At the bottom, you change the symbol and the axis. Don't do anything. First, the algebraic sum of both 1.5 plus 1.5 plus 1 is equal to 2.5. Below it becomes minus 1 at 90 degree. This is the transposition. So both are the same power. How do you know whether it is correct? If you look at the retinoscopy, plus 2.5 will be the other side, the distance correction. Okay, I'll show that. Drug correction, phenylephrine we have given. So there is no drug correction. What is the age? Around 48 old. So you have to give a age corrected vision. So 40 years we give 1, 45 we give 1.5, then 50 we give 2, 55 will give 2.5 and approximately 3 at 60. So this is normal age corrected vision. In between you can add another 0.25. But for people like who work as watch repairers, as a goldsmith, you need to give a perfect correction depending on what reading distance they need. That is called the Donders rule, which I will explain in the last. Here we have given plus 1. So what did we do? So plus 2.5 spherical minus 196 distant vision, and you have added 1 for the spherical alone. When you give glass prescription, you need to add that plus 1 only for the spherical. Whether it is plus or minus, you need to add. Cylinder will come down. Cylinder, astigmatism is for everything where a point focus cannot be formed. So just add that. The last part of the problem would be you have to give a diagnosis. How do you give a diagnosis? Here straight away there will be confusion. There is one sphere and one cylinder. So whether it is mixed or not. But here I will tell you it is a compound hypermetropic astigmatism. So minus at 180 I said is with the rule. But here it is minus at 90. So this is against the rule. And of course, the patient has got presbyopia. So it is compound hypermetropic astigmatism against rule with presbyopia. So just to summarize, you have a power cross of 3.5, 2.5. Distance correction minus 1 will become plus 2.5 plus 1.5. Subjective, you give 1.5 spherical and you subtract and give only 1 at 180, it will become 2.5. When you transpose, so use algebraic sum is equal to plus 2.5, then minus at 90. Just change the symbol and the axis. Now just look at the distance correction. On the subjective, 1.5 is your spherical power. And on the transposition, the other axis, 2.5 is the spherical power. That means you're perfectly right. So that is how you calculate. No drug correction, distance correction of +1. This is a glass prescription and you give a diagnosis. This is the simplest format. Just to go about with one more problem, 50 years homotripin. So what happens here? Plus 1.5 will become 0.5, but plus 0.5, what will happen? Plus 0.5 minus 1 is equal to, it will become a minus 0.5. You got it? Plus 0.5 minus 1, that's all, minus 0.5. So this is the distance correction. Now here both are same. You can take either of them as spherical power. If I take plus 0.5 diopter spherical, that means it is there everywhere. But how much do you want in 180 degree? You want minus 0.5. So you have to neutralize that 0.5. So you have to add both. 0.5 is equal to minus 1. Only then it will neutralize that 0.5 and give you a 0.5 at 180. So you give minus 1, you want it at 180, so you give it at 90 degree. It's a minus 1 at 90 degree. So actually transposition is not necessary here, but if you transpose, algebraic sum of 0.5 minus 1 will become minus 0.5 spherical, change the symbol and axis plus 1 at 180. You can see the other axis 0.5, you're right, but no need to do that. Drug correction nil and near vision add is 2 plus 2. Then you give this plus 0.5 minus 1, 96. And you're giving a plus 2 add. Just add to the spherical, add and put. This is the right way to put the precision. Plus 2.5 minus 1 at 90 and 6. Now, here you may think it's again compound. No, I'm going to say this is a mixed astigmatism. Minus at 90. Again, it is not minus at 180. It is against the rule. So, with presbyopia. Now you may be wondering, you're having one spherical plus and one minus. One you say compound and one you say mixed. How do we decide that? I will give you 3 problems to work. If you know, you say work out. One is a plus 2.75 spherical minus 2.5 180 plus 2.75 minus 3 180 plus 2.75 minus 2.75 180. All are one spherical and one cylindrical, which is negative, plus spherical, and so both are opposites. And you have a combination of plus and minus. What will be a diagnosis? Think for 10 seconds. Okay. I would say, most of you will say it's a mixed astigmatism as beginners. There is a way to differentiate this. If you transpose these 3, what will happen? You will get 2.75 minus 2.5 is plus 0.25 and plus 2.5. Okay. Plus 2.75 minus 3 will become minus 0.25. Correct. And the last one, plus 2.5 minus 2.75 will become 0 diopter spherical. Now see what happens. A becomes plus and plus. Minus will remain minus and plus, opposite only. And the last one becomes plus and plus, but there is one diopter spherical. So the diagnosis will be like this. Compound, first one is a compound hypermetropic astigmatism, all at minus at 180. So it will become with the rule. Second I say is mixed. Third one is simple. Why? See, remember when you have a sphere and a cylinder of opposite symbol, if spherical is more than that of a cylindrical, it will become the sphere compound of the spherical, compound hypermetropic astigmatism. If the cylindrical is more than spherical, or even if you transpose, there will be opposite axis, minus and plus, plus minus. So that becomes a mixed astigmatism. But if both are same, remember, it will become a 0 diopter spherical and it will become plus, that is compound simple hypermetropic astigmatism, only one axis. So this is how you say what is the diagnosis based on the problem. So what is this Donders rule I've spoken about? The Donders rule is to calculate for a person who is something like has a different working distance. Based on his working distance, you calculate scientifically the near version correction. So there are 4 rules to Donders. So you have to calculate what is the available power. How do we calculate? You ask the patient to read whatever near vision chart at a distance. You see at what distance he reads. Okay, the RF ruler can be used. After that, calculate what power is needed. Available power you want to know. what power is needed, keep 1/3 of the available power as reserve. This is very important, and give the required power. I'll give an example. Okay. So available power for near vision at 67 centimeters is how much? So patient is reading at 67 centimeters. Correct. So 100 by 67 is equal to 1.5. So the patient, I have a 1.5 diopter power. How much do I need to read at 25 centimeters? 100 by 25 will be actually, I will need 4 diopters. So if I have 1.5 with me already, if I want to read at 4, the normal tendency is to give a 2.5. So 1.5 plus 2.5 will become 4. I should be able. No. But you have to keep 1/3 of the reserve, because for stress and fever and all those conditions. So what do I have? I have 1.5 power. I will keep 0.5 as a reserve. So what is the remaining power I have? Out of 1.5, if I keep 0.5 reserve, that is wrong. So I'll have only one diopter. So what will you give? So instead of 2.5, 4 minus 1, I need to get a 3 diopter power. So this is a simple way of calculating near vision. Available power 100 by 67 is 1.5. To read at 25, 100 by 25 is equal to 4 diopters. Normally you will give 2.5 remaining, but if you keep 1/3 of my power, that is 0.5 reserve, I have only one diopter. So I need to give 4 minus 1. I will get a 3 diopter power. That is the basis on which this is done. This is how I calculated. You can see now how it is given. This is how we give a power. So this is something. If I have 5 minutes, I can show another problem, or I can stop, sir.
Sir, I think we are running right on time.
Right
so
on
the
time.
scientific committee chairman had told me that the chairpersons see to it that things
Yeah, I have finished. I have finished right on time. Thank you so much to all the chairpersons and Dr. Rajiv and KSOS sir for a wonderful. Hope I have tried to teach retinoscopy in a simpler way. Thank you so much, sir.
So thank you, sir.